Welcome to Evidence-Informed Tips for Physicians Making Decisions About Sick Leave and Return to Work. We're glad you're here. My name is Angie Hunt, Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC Government, as well as donations and memberships to WWDPI. We thank our program partners, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We'll collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You'll be emailed direct links for all of these items when they're available. As I mentioned, my name is Angie, and I'll be moderating the webinar and Q&A session. Our presenter today is Dr. Jennifer Christian. Dr. Jennifer Christian is an internationally known thought leader and advocate for improving health and functional outcomes and for preventing needless work disability in healthcare, workers' compensation, and disability benefit systems. Jennifer is a board-certified in occupational medicine with medical and public health degrees from the University of Washington in Seattle. She is a fellow of the American College of Occupational and Environmental Medicine and chairs its Work Fitness and Disability section. Jennifer is president of the Wability Corporation. She also founded the award-winning 60 Summits Project, a nonprofit initiative to propagate the work disability prevention model. It's produced 20 multi-stakeholder events in 2 Canadian provinces and 12 states in the United States. And now I'll hand it over to Jennifer.
Thank you, Angie. Hi, everybody. We're here to talk about evidence-informed tips for physicians making decisions about sick leave and return to work. What would be great is if you would, in the chat box on your screen, signal to us if you are a physician, or if you actually treat patients, or if you're in another role, because we're interested in who's actually attending this session. We're here because there is a gap in our society which is causing poor outcomes, and at this point in North America, it's not really clear whose responsibility it is to bridge this gap. And physicians and clinicians have an opportunity to step in and reduce the number of unfortunate outcomes that are occurring. Doctors in general, medical professionals, have not been trained to think of helping people actually successfully recover and get back to work as their job. The getting back to work part, or getting life back to normal, has been seen kind of as somebody else's job. And likewise, employers see it from their perspective as not their job either, because they tend to think of this as a medical issue. So people tend to fall down through this gap in our social fabric, and it creates needless work absence, job loss, and ultimately withdrawal from the workforce. And we haven't really understood until recently how devastating job loss is as a health outcome, as the pragmatic, practical, real-world outcome of a health condition. We've understood for years that death is a terrible outcome, and that, of course, sometimes includes needless or preventable death, so we have an opportunity to prevent them. But we haven't really seen job loss as the second worst possible outcome. I think we've thought more that impairment, the loss of a body part or a physiological capability, was the second worst outcome of a health, an injury, or an illness. But in reality, disability rights advocates keep telling us that you can have a great life with an impairment, but it is much harder to have a great life without a livelihood and without a sense of productive contribution to society. So the data is getting clearer that long-term worklessness actually causes declines in physical and mental health, as well as personal, family, social, and economic well-being. And of course, that includes needless or preventable work disability. So our job in medicine, obviously, is first do no harm, that we want to avoid these poor outcomes whenever we can. And as I said, worklessness is toxic. There actually is an analysis that was done in the United Kingdom that said worklessness, prolonged worklessness, is actually more toxic and more risky than the most dangerous jobs and many of the killer diseases, but we just haven't really recognized it as that. And then from the point of view of the person who's worklessness, humanizing this a bit, people end up feeling frustrated, angry, powerless, and full of fear when they get into a system that looks like they're going to lose their job, lose their livelihood, and then they end up in these big benefit programs, part of big government things. They feel very like they've lost control of their lives. And one person that was on disability here in the U.S. told me that every time I talk to doctors, I need to tell them that a lifetime on disability benefits is a life of poverty. And a guy in Arizona commented, yeah, it is nothing to do and no money to do it with. So we can see that a life that ending up with job loss and worklessness is really a poor outcome. The other thing that many of us have not been alerted to is that time is of the essence. When somebody's life is being disrupted, their life and their work is being disrupted by an illness or injury, the longer their life is disrupted, the longer they are out of work, the less likely they will ever be going back to work. This particular slide is from a population of workers' compensation claimants from a large American employer. And it is typical, though, of other slides. Some have a less steep curve, but it is a curve like this that turned me personally into a disability managing doctor, but mostly because I noticed out there at the far right-hand corner, the bottom axis on this slide is showing time away from work in weeks. And if you get out beyond about 28 weeks, and particularly if you get out beyond 36 weeks, you start to see that the number of people who are ever going to go back to work is getting vanishingly small. And in fact, what the slide shows on the left margin is the percentage of people who are going to ever go back to work. And as you get beyond, by the time you get to 12 weeks, you've already dropped down to 50% in this particular population. Other graphs show that you're down to 50% by something around 6 months. So the answer is, the short thing to remember is, with every passing day, the likelihood of ever going back to work is falling. And I also just want to comment that the World Health Organization has a very, very precise definition of health, which is the complete absence of anything bad and the presence of well-being in every dimension. And it is increasingly obvious to me that since 40% of Americans, I don't know how many Canadians, I imagine it's an analogous percentage, 40% of Americans are living with chronic illness today, and that the nature of human life is that hard stuff happens to us, it changes us, and loss is part of human life. That WHO's sort of pure definition of healthy is excluding too many people. And so there's a group in the Netherlands led by a woman named Machtel Tuber who says we ought to really be expanding our definition of healthy in light of that reality so that our definition is more inclusive. And so we ought to be defining healthy for all working age adults, including those with chronic conditions and disabilities, that it will include coping successfully with whatever challenges or hardships life has presented, and participating fully in human life and engaging in productive activity, paid or unpaid, for as long as is feasible. Because that's, as a social species, that's what we're designed to do. So the work disability prevention vision then is talking about the fact that time itself is toxic. Time in limbo is toxic. And from a pragmatic perspective, time is toxic because once somebody decides they can't work anymore, once somebody decides it's dangerous or inappropriate or too much to ask for them to work anymore, once that idea gets in their head, it's hard to get it back out again. And likewise, once their employer has decided that they can live without them, that it's not right to ask this person to work, that is too much for them, that they can't do it. Once that idea gets in the employer's head, it's also hard to get it out. So what we want to do is minimize the time in limbo from the moment that the patient and their employer are faced with a new health-related challenge to the moment when they've coped with that new challenge. Now, it may be some of the time that how they're coping is they're going to decide you're never coming back to this job. But it is okay if that is clarified soon, because the person won't necessarily have decided that they can't work at anything. They may just say, oh, okay, with my bad shoulder, I'll have to go work someplace else. It's the time in limbo, the time spent defining oneself as too sick to work, that is really the problem. So the idea of work disability prevention, the model of work disability prevention, is we want to reduce needless work absence. If people really need to be away from work, we have only a modest opportunity to reduce it. Conceivably, we can reduce it by improving diagnosis and improving treatment, but really most medically required work disability is due to the body's response to insult, to the chemical cascades that get set off by the onset of a condition. A lot of work disability is due to decisions, discretionary decisions that are being made by somebody that that would end up either with them able to work or not, and the discretionary decisions today are causing work disability. We can change them. And then the third group is medically unnecessary work disability days, which are basically due to administrative complexity and bureaucracy and basically inexcusable silliness. It is very hard to get rid of all medically unnecessary work disability. Any of us who have ever worked in complex organizations or systems know how hard that is, but it is unjustifiable from a medical perspective. Now, doctors and other clinicians have some unique power to influence the outcome because we provide factual information and advice. And our factual information and advice is going to either encourage and support or discourage and obstruct the other stakeholders in the situation, the other participants in the patient's situation, to stay at or return to work. And one of the great terms I've heard, the Associate Medical Director for the Washington State Workers' Comp System said, you know what, we're the designated guessers. Generally speaking, I don't know anybody that went to medical school because they wanted to opine about whether or not a patient could go to work and what they should do there. It hasn't been these opinions and this knowledge and thinking hasn't really been part of the standard medical curriculum. But we've been pressed into service by others because they want somebody to serve as the objective corroborator that something's happened or something's going on, fundamentally because they don't trust the worker. They see the moral hazard, the vested interest, and they want to have a trustable third party to opine. And then also they have blind faith that doctors know everything. They overestimate what we knew. So the awkward part, though, is, as I said, medical school hasn't really trained us to do this work, and these issues are actually not considered medical. Most doctors that I know think of them as kind of administrivia. And I know for me, I personally am tremendously irritated at being asked questions that I don't really know how to answer. And so if we haven't been trained and the science behind our ability to predict is weak, which is true, and we're not paid for the time or effort we have to spend on it, we tend to resent the work. However, we are the best available choice. If you look around in society and you say, who is in a better position to provide this information in a timely, cost-effective manner, the answer it is the treating doctor. So there is a peril that happens, however, and I call it transubstantiation, which is that doctors' wild guesses are transformed into immutable true facts by the recipients. And the important part of being aware of this transubstantiation problem is that your wild guess, a wild guess, may be inappropriate. It may hold somebody away from work. It may expose somebody to risk. And the take-home message really ought to be that we don't allow other people to turn our wild guesses into gospel. We have to let people know that we are making estimates based on the information we have at hand, and that we can invite others to provide more information or to problem solve with us so that our decisions will be helpful instead of obstructive or dangerous. Now, the way you can create work disability is there need to be usually at least two of these ingredients. You need to have a medical condition. The patient needs to have a medical condition that's affecting function, some function that they need to either get to work or do their job. And either they have to lack the ability or the willingness to cope and work around that problem, and or their employer or others failing to provide them with external support. And it's not just a medical condition, because plenty of people with medical conditions affecting function work it out with their supervisor or figure out a way to work around it themselves. So it is this other thing, is does the worker have that ability to cope, and or is the employer being supportive? So if we're going to try and reduce work disability, we do have some opportunity to reduce the length of work disability by increasing the extent and speed with which function affected by the medical condition are affected, by improving access and reducing delays in care, increasing the effectiveness of our treatment, otherwise known as doing the evidence-based medicine, and paying specific attention to function as part of the treatment, with the idea that time is our enemy and we are really playing to try and get people back to function. Symptoms are a secondary issue. And secondly, the other technique is to restore or shore up the worker's motivation and ability or willingness to cope with a situation. And lastly, to persuade others or take advantage of the willingness of others to arrange workplace and logistical support to enable this person to restore the normal rhythm of daily life as soon as possible with a stay-at-work or return-to-work plan. Now, the patient, the affected individual, actually has the most power to determine the eventual outcome of a potential work disability situation, because he or she decides how much effort to make to get well and resume normal life roles, to exit the life state. The weird part, of course, is the individual often feels powerless in these systems. Doctors feel powerless in these systems. Employers feel powerless in these systems, and yet they each have a significant ability to influence what happens. So when a person is newly injured or ill, this person who has all this autonomy and power and everything may be flummoxed by the maze that they're entering, and they may be new to the health system and this kind of issue. And they will reasonably be wondering, like, how am I going to do this? This is a new issue for me. I haven't had a medical problem before. I haven't had a medical problem that affected my work before. And they are reasonably going to have a lot of questions. Now, I put together this list because I was going to be presenting at a hearing in Washington, D.C. to federal policy people and disability rights advocates and stuff. And part of what I was trying to teach them was the power of the answers of these questions. That depending on how the person sees their situation and the kind of advice they've gotten, they are going to come up with a different strategy for how to manage this episode and what to do about it. And as I was presenting this list and saying, don't you think these are pretty reasonable questions that people would have? Like, how long am I going to be out of commission? How long do I have to take it easy? What should I still do? What can I still do? What shouldn't I do? What should I do to speed my recovery? What does this mean about me? What does it mean about my future? Who's really going to help me with this? As I was presenting the list, I suddenly realized that in the standard structure of a medical encounter, which I believe we have all learned, the format for the encounter and the format for the note, there is no place where we answer these questions. We do answer the first and second bullet. What's the matter with me? We may or may not answer what caused it, because having a diagnosis is not the same thing as really the answer to this question. And what care do I need to feel better? That may not be actually even quite enough either, because the treatment may not be enough. It may be the patient needs to do some stuff, but at least we are all trained to do the first and second bullet some. But we are actually not, as part of our standard medical care, attending to these reasonable concerns of working people whose lives have been disrupted. Now, some people that we're seeing are people who are destined to have a poor outcome unless something good happens. There are negative factors that increase the negative impact of health on work. They've been studied quite a lot. This list here of personal and psychological features and health status and social factors and workplace factors and economic factors, if somebody starts to accumulate a bunch of these, they really become at high risk for poor outcome. And many of these personal and psychological factors are in fact very powerful because, as I said, the way the person sees their situation, the expectations they have, and their understanding of their condition and what's safe and it's not safe for them to do, that is going to have a big impact on how they manage themselves. And there is an especially vulnerable subgroup, those who have a high ACE score. And I wish I knew right now, if we were looking at each other, I'd ask you, have any of you heard of the Adverse Childhood Experiences study that was started by Kaiser Permanente in California and then picked up by the CDC here in the U.S.? I have to just cough here for a second. So anyway, the idea is that having had different kinds of adverse experiences in childhood is the more different kinds of these adverse experiences you have had, they are associated with worse health outcomes and functional outcomes in adulthood. And I'll show you a slide in a minute that shows that it is very clear that this influences how people respond to stress in their life and how they manage challenges in their adult lives. So CDC has conducted telephone surveys in 6 states, and we now kind of have a rough idea that about 10% of the U.S. population actually has a high ACE score. So there is a subgroup of people who, as a result of their childhoods, are less likely to cope well with the onset of a new injury or illness in adulthood. And you can find out more at the websites here on this acestudy.org or on the US CDC website by typing in ACE study. Now, and here, this is a chart, this next one, showing the dose-response relationship between ACE score and some conditions that are of interest in people who are having, working people with an injury or illness. The first, if you look along the bottom, the conditions are unexplained symptoms, alcoholism, absenteeism, serious job problems, and depression. And the colors in the bars are zero ACE score is green, and red is a high ACE score of 4 or more. And as you can see, there is a very clear increase of the bad things as the ACE score is going up, and most extremely for unexplained symptoms, people who have symptoms in excess of objective evidence of disease. And I have worked for insurance companies, and I have had clients that are in insurance companies, and we've looked at they call it the book of claims, and it turns out that when you talk to almost every workers' comp carrier, every disability carrier, and every health carrier, that a very small number of people account for almost all of the costs in these insurance companies. So probably what we're looking at is, when we talk about 10% of the population having high ACE scores, that among the small number of claims, which are the highest cost claims, there are probably a lot of people packed in there who had a lot of biopsychosocial risk factors, including high ACE scores. The part we need to pay attention to as clinicians is they all walked in the door the first day with their first visit for a new injury or a new illness. If we look at the cases in these high-cost percentiles in insurance company folders, basically it was a very big shock to me the first time I ever went through a listing of claims that ended up costing more than $500,000. How many of them started out looking like a little nothing, like a backache, like a bad big toe, like wrist pain. And so in that group of claims that were costing more than $500,000, there were certainly classic catastrophes. Ones that looked serious on day one, they had obvious either imminent or already occurring anatomical functional loss or multi-system insult. Could have been a congenital issue, a devastating illness, multi-body part trauma, etc. But these other ones, we're now calling these creeping catastrophes because they started out looking like a common health problem, but the recovery stalled, nothing worked, the illness was greater than the disease, and that person's desperation, and maybe the desperation of their doctor, drove the search for expensive and ever more destructive measures. The people go downhill over time, and these lost causes end up on benefits forever. So this is a group where we won't be able to make a difference in every case, but maybe what we can do is nip some of these in the bud so the person is able to avoid that pathway. And once you get to be a creeping catastrophe, then you are really stuck in the maze after an injury or an illness. And what we want to do, I think, in order to prevent needless work disability in this most vulnerable group is to get them the heck out of the maze as fast as we can. Now, there are some positive influence on how much impact health is going to have on work. And you'll see in white here that the ones that are really inside the worker are respect for the employer, their job satisfaction, some feeling of moral obligation, playing by the rules, etc. And if they have reasons why going to work is a pleasure for them or good, for example, their relationships with their coworkers or feeling needed, feeling important. But there's some others here where the doctor can make a difference with strong health literacy, so that the patient is feeling like they are in charge of their life and their health, and they see the connection between their health and having a life they like, rather than handing it over to the doctor, and having well-managed chronic health conditions, which, P.S., also has a lot to do with the skill of the patient at doing their part to manage their chronic health condition and the attention of the doctor to the part the doctor needs to do, and then positive behaviors, beliefs, and confidence. So here we are again, that how the patient thinks about it from a negative point of view can have a big impact, and likewise how the patient thinks about it can have a positive impact. And positive behaviors, beliefs, and confidence can be created through thought and behavior changing techniques, education, skill building, emotional support, I should say that, having somebody stand for you, champion you, build your own confidence in yourself, and specific psychotherapies, for example, cognitive behavioral therapy. And we need to remember that getting those thoughts on the right path is something that needs to be done and is easiest to do at the beginning when it's new and you have kind of a window of flexibility before the person has made a bunch of decisions. Now, the other party who's very important is the employer, who plays the second most powerful role in determining the outcome, because the employer decides whether to manage the employee's situation actively, passively, supportively, or hostilely, and whether to provide for on-the-job recovery. And yet, in our nations that have now more and more small employers, and even in large organizations that have sophisticated top management, first-line supervisors and small employers are often naive and uncertain in dealing with injured or ill employees. In their minds, these are medical issues, they don't know anything about it, and they want to not hurt anybody. They are unfamiliar with the medical world. They are unfamiliar with medical jargon and workers' compensation jargon. They sure don't want to be responsible for hurting anybody, and they also generally are good people who are kind. They don't want to be a negative. They don't want to be the guy who makes anything bad happen. And if they work in an organization where there is financial or management accountability for injuries, they sure don't want to be responsible for a re-injury or another injury. Also, these small employers and supervisors often just can't imagine ways to adjust jobs. It is remarkable how, as my grandmother would have said, if it was a snake, it would have bit them. Sometimes the solution is sitting right there, but they simply can't imagine it. And they are so busy, they have no time spending fooling with us. So just as a tiny story, an Octoc friend of mine, medical director for an insurance company, went kind of on a riding shotgun on a visit to an employer on a case that they'd had trouble getting back to work. And so who was going to be there officially for the meeting was a physical therapist who was going to be looking at the job, and a supervisor and the worker. And so my friend Gideon was there. So what Gideon saw go on was a conversation between the PT where they and the employer and the worker, where they ended up saying, okay, so it looks like the only part of this job that Janine can't really do is lift that heavy thing, and she has to do it just really a couple times a day. And the PT said to the employer, do you think you could get somebody else to lift that heavy thing for Janine a couple times a day? And he said, sure. And then the supervisor said, you know, they kept calling me and asking me if I had modified duty, and I didn't know what that meant. So the naivety and the barriers we put up with our language, we have to just really realize who we're talking to. So human beings are doctors, human beings are patients, and human beings are employers, and human beings are benefits people, and we vary in our quality. Now, I tend to use this slide more when I'm talking about patients, that you're going to have a universe of patients where some of them are going to definitely have a good outcome. They're like Boy Scouty, Girl Scouty, work-addicted people, very cheerful, love their jobs, and no matter what we all did, they are going to fight to get themselves back to work. And then there's a group who have had an absolutely devastating head injury. You know, they are never going to regain consciousness. It's very clear that outcome is going to be bad. And there are also people who, you know, are basically criminals. They are attempting fraud on day one. But the vast bulk of people are not in those groups. The vast bulk of people are in the good on less group and the bad on less group. And the good on less group is perfectly good people who are planning to go back to work, but if they are treated like a number or betrayed or neglected or made fun of or treated rudely, they are going to get mad. And they are going to start standing on ceremony, looking for their rights, and basically becoming very passive. Like, I'll go back to work if you make me. And then there's this other group called bad unless, which is, and in Canada there may not be any people like this, but there are parts of the United States where people are reared in a culture which is kind of, there's no rule that isn't made to be gamed, and they just are out to play a game and get around every rule. It's kind of a culture of disobedience, I guess you'd call it, what you can get away with. And those people are going to head south and become a bad outcome unless somebody pulls them up, puts them in the spotlight, and teaches them some limits. So clinicians have a possibility to influence which way those groups in the middle go. If on the day one, a good unless person gets ignored, disrespected, abandoned, alienated, unmonitored, no limits, they're going to head south towards bad outcome. But if they are treated right, they're going to stay up there in the good outcome group. And likely the bad unless group, if they are noticed, cared about, valued, respected, and some limits are set, and it's clear that the signal is set that we're going to play this straight and according to the rules, you can pull a lot of those people up and they will fly right. And now I just want to work on some of the mechanics of evidence-based clinical decision-making in stay at work and return to work. I'm going to go through this rapidly. You'll have the slides afterwards. There are a set of steps to make, cognitive steps, when you are trying to decide whether on this day this person can work, and if so, at what. And there are a set of resources that are available to you, and I'm going to go through this pretty rapid fire. So just overall, an evidence-based approach to making these decisions is to remember that the goal is to avoid iatrogenic secondary consequences of that injury and illness on the worker's life and future, and help them optimize recovery, keep their jobs, and stay employed. That is the context within which we're doing this work. And to assume that time spent in limbo is increasing the risk of a poor outcome, and to really focus on days 0 through 42, through the 6th week, because most biological things, most tissue injury has healed by about 6 weeks. So in that 0 to 42 period, we're saying, what can we have this person do while the tissue is healing so that we are setting clear expectation and getting things off on the right track so they'll be able to go back to full whatever they're usually doing by the time the tissue's all healed. And during that days 0 through 42, what we'd like to do to the greatest degree we can is preserve the normal rhythm of life and get them right back on the horse ASAP so they don't develop anxieties about whether or not they can function. So we're going to be focusing treatment on the recovery of function, and unless confinement to bed or home is actually medically required, we will be describing the circumstances under which they can work safely. And we will okay and be happy with a two-way exchange of information as needed in order to facilitate stay at work and return to work with the employer and others involved in this situation. If you don't feel like you have enough information to make a good decision, make a provisional decision today, and then ask for more information and let them give it to you. And also likewise, if your instructions aren't clear to them, allow them to ask you follow-up questions so that this transubstantiation problem doesn't get in the way. And then if you see that the employer and the insurer are uncertain about interacting with you, because some of them are, they're afraid of doctors actually, is request them to be part of the problem-solving team and look for and suggest solutions, like how could we make this work? That is a wonderful question because that gets us into problem-solving mode instead of factual determination mode. And as you'll see, there are we need to identify and resolve non-medical obstacles. That doesn't mean that we resolve them, but there is no better professional group in the Western world to distinguish between medical and non-medical obstacles than physicians. We are the ones who can really tell you what's medical and what's not. So the steps in formulating an opinion are, first, is work avoidance really medically required? And if yes, then we have to remove them from work. Usually the period of work avoidance is relatively short. We'll talk in a minute about how it looks. And so we have to remember to rethink the issue as soon as we think that medical requirement has disappeared. If no, and work avoidance is not medically required, we want to figure out if there's a mismatch between what they have to do at work and what their current medical risks are and their functional limitations, their capability shortfalls. And if there is a mismatch, then we need to formulate an activity prescription to guide both the employer and the employee, and identify and handle pertinent non-medical issues, communicate the activity prescription even if no work is available, because it is a powerful signal to say off work. It's a powerful negative signal. So what we want to be constantly be is the people who say, you could be working, you could be doing this, and let it be the employer's job to say, no, I don't have work that meets those criteria. But we don't want to be teaching people they can't work. And then monitor and revise the activity prescription at follow-ups. So work disability is medically required when the person really needs to be at a place of care, at the hospital, at a day treatment center, if the PT office is only open during business hours. And work disability is also medically required when the recovery requires that somebody be at home or in bed. Usually what we're really talking about here is during the acute response to injury, the biochemical cascade, the period when we're being prostrate and we're having so many symptoms we can't really function. There's also the possibility of risk of contagion, that's safety for other people, and also the need for a protected environment. Some people, actually, even though they need to be confined to home or bed, could work, right? So it doesn't automatically mean that you can't work. So generally speaking, when we talk about work disability being medically required, it's that you are so unable to function that you are really, really sick, right? And then thirdly, there may be conditions for which work or commute are medically contraindicated. And by that, what we mean is that it will worsen medical condition or delay recovery. We don't mean causing symptoms, because symptoms don't harm people. They make people uncomfortable, but they don't harm them. And we're talking here about medically required, meaning that a risk of harm is present. Now, there are way more times when the circumstance is the problem rather than the condition. I'll give you an example. I used to work on the North Slope of Alaska at Prudhoe Bay, and we had a guy that wanted to work there who had hemophilia. And I said, I'm sorry, it's medically contraindicated for you to work on the North Slope of Alaska because we don't have any blood here. The only way we can get you out to a hospital is by jet. The nearest The hospital's an hour and a half away, and we're often weathered in. It's just not safe for you to be up here in case something happens. However, most people with hemophilia can work just fine. So the problem actually wasn't his hemophilia. The problem was the circumstances that we were on the North Slope of Alaska. So one way when you're trying to decide if work disability is really medically required, you have to say to yourself, if I change the circumstance, does that contraindication go away? And in this case, there is no medical requirement for work disability if you have hemophilia. There is one if you have hemophilia and you're working on the North Slope of Alaska. So we have to be careful to avoid illogical assumptions. The fact that somebody has a diagnosis doesn't necessarily mean they have a functional impairment. Like, there actually are a remarkable number of lost work days that are attributed to high blood pressure and diabetes. But I have a hard time figuring out, like, what can't you do? Why can't you work if you have high blood pressure? Maybe you shouldn't, try and pull up heavy windows that are really stuck and do Valsalva maneuvers, but, like, why couldn't you go and do a desk job? And then having an impairment actually doesn't mean that you need to be work disabled. As a matter of fact, the Americans with Disabilities Act and all the Human Rights Acts and the disability rights advocates are reminding us that people with impairments deserve to and want to work. So why is somebody work disabled, for example, if they have a sprained ankle and they work at a desk job? If you can figure out some way to get them to work and you can make it so that they have a way to get to the bathroom and back, like, why can't they do their work? So we have to be careful here about these false equivalencies. Now, work disability is medically discretionary when a person could do something useful, but there's no way to get them to work. The person is incapable of any substantial work. It takes too much effort to support them. The employer can't find work within these restrictions. The company policy or the union contract prohibits light duty. The insurance policy or the law says blah, blah, blah. And somebody's worried he can't make it. He'll just get fired. Now, these are discretionary decisions, and somebody is making the decision to have there be work disability. They didn't have to make that decision, right? They could have made it the other way. And the question is, who is the person that's making these decisions, and what kind of decisions are they really? These are actually cost-benefit decisions by a business person. But what happens is the business person would like to blame it on the doctor. So one of the important things that you don't want to do is get employers off the hook and have you be making business decisions on their behalf. That's their job. Your job is to say whether or not it's safe for this person to come to work and do something productive, and for you to help identify the things that it is safe for them to do, and let the employer be responsible for managing their business and making employment decisions. And work disability is medically unnecessary when all the things on this list happen, and that's non-medical issues are not addressed because they're masquerading as medical. When there is bureaucracy delaying or making medical care inadequate, when you don't have enough information about what the job is, or you don't give enough information to the employer about capabilities. In other words, when medical time lost from work is really due to communications delay, poor information flow, anyone's ignorance or resistance, administrative and procedural delay, flabby management, and poor accountability. The thing is, it's really hard to get rid of all of these bad things, but every day that somebody is away from work, their likelihood of going ever back to work is going down. So these completely medically unnecessary, unjustifiable reasons for being away from work are causing harm, and so we should just try and get rid of as many of them as we can. I want to clarify a little bit about here that when people talk about medical restrictions, there's the word restrictions and the words limitations, and it turns out that some people use them to mean one thing and the other use them to mean the other. But I need us all to be clear in our mind, they are slightly different. I call restrictions, because I think of restrictions as like a restricted area. You're not allowed to come in here. And that's what we mean here. These are things that the patient should not be allowed to do because there is a medical issue. It's what the worker should not do, what the employer should do to protect the worker. And it can only be modified by the doctor because we theoretically are the ones that really understand medical risk. The employer may actually understand safety risk more than we do, and other kinds of medical restrictions are due not to risk just to the worker, but risk to others. So the employer may have something to offer about safety concerns that you should listen to. But again, this is something about allowing, and a person who actually knows what they're doing really needs to authorize any changes, because if not followed, medical harm or harm to the public may occur. The other idea here is limitations, where we're talking about whether or not somebody's simply capable of doing it. And this is, the issue is, what can this person do today? And the doctor is basically serving as an objective assessor. This is the designated guesser part. And in my mind, this should be able to be modified by agreement. I actually don't even get why we have to be in the middle. And if you have a worker and an employer who are getting along fine and they trust one another and they want to modify it, hey, go ahead. But it may be that you're in a formal situation and that you have to sign off. But what you can say is, hey, you guys work it out. Come back to me and I'll agree it. That will just, there's no reason why you need to make a guess it's wrong. This is also in the transubstantiation area. There will be little or no harm if it's not followed, as long as it really is within the worker's capability. So when you're talking to people about restrictions and limitations, and you're talking about how long they're going to be away from work, your words are going to have a very powerful impact. The data on placebo and nocebo, I don't know if you've heard of it, but placebo is kind of a positive thing, and nocebo is the evil twin sister of negative stuff that happens. And most of what causes placebo and nocebo is the clinician's words and behavior. It's not the red pills. It's what we say about them. And it's what we predict, and it's how we behave. And just as an example, what they have, there are studies now that if a patient sees you administer the opioid drug, it will have twice as much pain-relieving impact. So it's not just words, it's also just knowing you've gotten the magic juice doubles the effect of the known narcotic. Okay, so for many problem issues, physician advice has been shown to affect the outcome, like abstinence from alcohol, how they take their drugs, whether they wear seatbelts, do exercise, do nutrition. It isn't that 100% of them do what you say, but it improves the likelihood that they will. So this is a similar area that for patients with everyday complaints, what you tell them may actually be the most important thing you do, the words you use, what you educate them about, and your predictions. And obviously for patients with serious medical problems, these things may even be more important because you're helping them figure out how to minimize the impact of this injury or this illness on their lives and livelihood. So you want to avoid the nocebo effect on everyday problems and choose reassuring words. We all have been sort of trained to tell the patient the diagnosis and pull out the model of the spine and describe the working of the knee and give names to things that sound fancy so that the patient will go away comfortable that they've had a diagnosis. The problem is, how can you ever feel good about your knee again after somebody's told you it's bone on bone? So what we want to do is choose reassuring words that don't create illness. We want to say normal aging process, your back looks kind of like it's the same age as the rest of you, you got kind of gray hair on the back, you have problems with backache, and also to give people advice to stay active and not get them in an overprotective posture, because fear of movement, fear of pain, thinking they're going to hurt themselves, all that stuff is going to lead to likely to lead to a worse outcome. There are a group of resources you can use to identify medical risks. This is a list you can use later. Unfortunately, there really is no kind of encyclopedic or authoritative resource on risks by job or risks by condition. This is really basically your fund of medical information and what you can find from talking to other people and reading. There is a quick little convenience store test you can use to think to yourself, if he or she owned his or own little mom and pop convenience store, would he or she be able to find a way to work safely? This gets you out of the particular context and the work environment they're in today and puts them into this little, I run my own shop, I'm in control of my own, I own the methods and materials. And if that person still would not be able to come to work, you are probably looking at a real medical problem. Here are some resources to estimate the impact on function, on what their actual limitations are at this point. And I'm going to just very briefly teach you two little seat of the pants tests you can use, but there are obviously more fancy things that are listed here. The 1-minute return to work screening test is and I've done this with many patients, and you can put a stopwatch on it. It really is very fast. They are going to be matching up in their mind as you ask them these questions, what they know about their medical condition, their current ability to manage life, how to function. They're matching it up with their own job. And so you ask them, what impact is the problem with your knee going to have on your ability to do your usual job in your regular way? And you're just asking them to zero right in there for you on the topic of the issue of interest. Then what we do is we ask them, have you figured out a way to work around it so you can stay on the job while you recover? Because here, remember I said in the recipe for work disability, you have to have a condition that is having an impact on their ability to function. And we're here with number 2, have you figured out, we're measuring or assessing their ability or willingness to cope with it. And the third one here, are you going to have any problems with your boss or your coworkers about that? We're doing a quick test here to see what kind of support they're getting at work. And once we get the answers to these questions, we are going to know what the issue is we need to work on. And just to get it a little bit more precise, when people are being vague, they say, well, the reason why I can't work is because of my pain. You say, what specifically is the obstacle preventing you from working today? Oh, it's my pain. Well, what can't you do specifically because of your pain? Because when we start really pinning people down, we start discovering that the problem is actually childcare, or the problem is that they can't walk up the stairs, or the problem is they don't know how to drive, they're not comfortable driving. All that helps us identify what the temporary adjustments may need to be made in order to help them work. In order to obtain information about job demands, you can use that 1-minute return to work screening test I just taught you, and there are a lot of other ways to find it from worst to best, and the answer is use the best available. And there may not be anything very good, but the thing we have not really used quite enough is just asking somebody to do a cell phone video of the job. That is so ubiquitous and so easy as a way to understand what a job looks like. So you may have the worker be able to do it, or have the employer send you a video. There are also, when you have to say how long you think somebody is going to either have limitations or until they're able to resume full duty. There are 2 commercially available main resources. One is MD Guidelines, and the other is the ODG, the Official Disability Guidelines. My personal preference is for MD Guidelines because the underlying integrity of the data set for MD Guidelines has historically been superior. And as you can see, they offer suggested durations that go from the soonest anybody would be able to come back to work to the maximum when it would really have a medical reason. If you get out beyond the medical, that usually means, if you get out to the maximum for MD Guidelines, or you get out to the at-risk for ODG, what that's really telling you is there's not really a medical reason for this anymore, or there most likely is not a medical reason. What you're really seeing is non-medical obstacles to return to work. And then because non-medical obstacles are often what is really delaying return to work, it is important for you to learn how to look for them, particularly, as I say, because these people who are destined for a really poor outcome, it is often a non-medical issue. And if you want to help that person have the best possible future, you got to be able to put sunshine onto what the issues are. So fastest way to recognize it is when you see somebody making a mountain out of a molehill, or when an apparently minor health condition is having a major effect on daily life and function. That probably shows you there is a non-medical issue working, and it often is a motivational one. What you may not know is whose motivation it is. I have learned since I put this together that also people with high ACE scores who are having these medically unexplained physical symptoms, their emotional or historical or memories may be creating the symptoms, and it's going to look like they're making a mountain out of a molehill because they have their body is the way that our emotions are expressing themselves. So obviously you're going to need to attend to it in a different way. So tolerance, though, is not a medical issue. Tolerance is the patient's ability or willingness to put up with subjective chronic pain or chronic fatigue. Choice is involved. There is human autonomy here. These are actually human or humanitarian issues. This is where it's the most awkward to be in the middle, because it's medicalizing something that really isn't a medical issue. And you have to be yourself alert here that you want to distinguish your social justice impulse from your professional franchise. We have been put in the middle because we know medicine and because we know medical risks. We haven't been put in the middle to be social justice activists. So it's hard to say how to handle it. Sometimes pain does make people weak, right? Sometimes people who have just had surgery do have reduced stamina. So when we're talking about tolerance here as non-medical issue, it's usually in the face of chronic conditions with no ongoing tissue damage. And explicit clarification that it is a human issue and there is a choice is often helpful. Sometimes it may boil down to asking the employer whether they are willing to have somebody be in pain every day, or whether they're willing to make an accommodation for subjective comfort. And sometimes it is a time to have a conversation with the worker. Given that you're going to have knee pain for the rest of your life, are you willing to go back and do this job, or are you going to go get yourself another one? So there may be issues in many other dimensions, and these can be interfering with recovery. The healthcare system right now is not that strong on dealing with them, but it's a good idea to at least speak what they are so that we know what the real issue is. And we want to avoid medicalizing stuff that is not actually medical. Patients may not realize that pain and other symptoms can be exacerbated or even caused by simmering and unresolved non-medical issues. Normal human reactions to life upset or like a new injury or illness, grief, confusion, and anger, they are not mental illnesses, but they need to be attended to and managed and acknowledged as issues. People who are dealing with a new episode need to strengthen and be encouraged to strengthen their existing coping resources with sleep, nutrition, and exercise, and to not isolate themselves and rally their social networks. And as I say, it's really important to help patients distinguish between medical and non-medical issues. Sunshine is a great healer. So, as I said, there are a lot of reasonable questions that people have that our medical training has not prepared us or hasn't given us a format to do. So I'm starting to think we ought to put a new section in our standard format for the visit and the report in which we explicitly remind ourselves, cue ourselves to address these topics for the patients, because our words, our predictions, and our advice are so important. And employers need education too. We have to be careful with them with jargon. And one tremendously helpful thing is to distinguish between temporary adjustments to a job and permanent changes because of a long-standing condition. They're going to look very differently at a temporary short-term adjustment with a clear end period than they are at the idea of potentially having to change something forever. They're very different questions. So the take-home messages here is that worklessness is a poor clinical outcome. You can have a powerful influence. Your guidance either encourages and supports or obstructs and discourages efforts that stay at work and return to work. And getting people right back on the horse prevents needless work disability and helps people keep employed. So the specific things you can do to be more helpful are to decide you're going to avoid creating iatrogenic invalidism. That's people who think they can't when they actually could. Avoid creating iatrogenic invalidism and job loss. keep life as normal as possible, minimize disruption, prescribe activity and work carefully as part of the therapy, speak carefully and harness placebo, not nocebo, predict typical timelines for recovery so that people see that there is a recovery coming, avoid medicalization and make it clear when non-medical factors are the reason for time off, and help people succeed at work and keep their jobs. So my time's up, but I do have, I think, if anybody wants to hang around and ask some questions or comments, I would, if you want to start entering them in now, in the text box, Angie will interrupt me when they arrive. Angie, are there any questions already?
Yeah, there are. I can go ahead and start. At the beginning of the slides, you mentioned some statistics for the U.S. on unemployment, but do you have any similar statistics for Canada by chance?
Statistics on what?
On the disability claims. It was the very beginning of the slides.
I don't know if I can go quickly back to the very, very, very beginning of the slides. Oh, you mean in terms of people job loss and things like that?
Yes.
I think I don't have them.
Okay.
I'm sorry, I don't.
Just to go back to the questions of our audience, we did have a few, a lot of people were in different roles. We do have people who treat patients as part of a pain program, chiropractors, occupational therapists, that sort. So just a cross-reference of our audience. Another question.
Oh, thank you for telling me who you were. That was great.
Another question that came in, we did talk about tissue healing, the time it takes for tissue healing, but what about mental health issues on disability claims? Is there a timeline for that?
Timelines for mental health issues are harder, and I think it's really important to distinguish between serious mental illness like psychosis when the brain is clearly chemically dysfunctioning in a really big way, versus anxiety and depression. And here in the U.S., and I am from the U.S., I have not had projects in Canada to work on this in the system level, but here in the U.S., increasingly in the last 20 years, people who are ending up on the big federal disability programs started off with common everyday conditions like musculoskeletal conditions, anxiety, and depression. And I took a look at the statistics. It's now roughly half of the people coming on the federal program started off as, these are really creeping catastrophes. People who had something that should never have ended up having them lose their livelihood. And so when we do anxiety and depression, just like we think about low back pain, is you say, how can I normalize life for this person? How can I keep them confident? And that it is not a good strategy to remove them from work in general, unless they are so cognitively impaired they absolutely can't do their job. And what would make more sense is probably to temporarily adjust the job rather than to separate them completely from the workplace. One of the things that made me see this is to flip some statistics backwards. And one of them is all the statistics we keep getting about how much undiagnosed depression there is, how much undiagnosed and untreated anxiety there is, the people who are basically whining and complaining that we don't have enough mental health treatment. If you turn that statistic upside down, what it tells you is a heck of a lot of people with anxiety and depression are able to stay at work.
Jennifer, are you still there?
Any other questions ready?
Yes, okay. So there was a comment, you mentioned, mentioned the stats in the U.S., but there are definitely our share of employees and culpable absenteeism here in Canada. So that's just a comment from one of our audience members.
Could you say here in Canada there's what?
Oh, our share of culpable absenteeism here in Canada. So we do have our share
yes.
in Canada too.
Well, there are a lot of times when if we went to any developed country, we're going to see the same human beings there.
Mm-hmm.
And when people, the United States has 50 different workers' compensation systems, and I don't care that much about what the system is because there's human beings always in it, and these dynamics are always there.
Mm-hmm.
I'll give you the most extreme example. The most negative employee-employer relationships I've ever really seen are in the U.S. Postal Service and also in the big auto industry. And I was at a meeting once with a big auto company, and they were talking, basically they were whining about how hard it was to them to manage work disability because they had so many, oh, I can't remember the word now. It's that word when you have a swimming pool and that invites the little children, attractive nuisance. Their benefit programs were so generous that, like, why should people even bother to come to work? Because when they're off work, they're getting paid more, et cetera, and they were all feeling so sorry for themselves. And I said, well then why is anybody at work?
Mm-hmm. Yeah.
Right? And so, again, this is like the anxiety and depression statistics. If you turn it backwards, what you say is, okay, you may have attractive nuisance benefit plans, so what you have to focus on is why do people come to work and have more of that happen.
Mm-hmm. Yeah. Another question, moving on. As it's becoming evident that doctors are not always the best to deal with stay at work or return to work, do you think there needs to be a shift from the insurers as to acceptance of authorization for return to work? For instance, insurance companies always require medical clearance or a doctor's okay to return to work when the physician might have better information, or an occupational therapist know more about the job and how to gradually get the person back to work or modified duties.
I don't know. I don't think I am prepared to really answer that question. It is obvious that sometimes there are people with different amounts of expertise in this situation, and in general, I think the person who knows more ought to have credibility. But it's also true that as a social solution, remember I told you that doctors are the designated guesser. One reason why the doctor is the best choice is they're the most multifunctional. Mm-hmm. Occupational therapists are probably not appropriate to talk about infectious disease or stuff like that, right? And so if you're looking at a large-scale social solution, I would say doctor's still your best guess. But it would be, I think there ought to be a duty to take advantage of the best available information. And when we talk about evidence-based practice, one of the hallmarks of evidence-based practice is you have an ethical imperative to use the best available information. And sometimes what that looks like is the best available research studies, but sometimes what that looks like is the best available data. And, you know, somebody who's actually studied carefully what somebody can do and has actually observed them, it should obviously have priority over somebody who's made a wild guess. But I would think it would be appropriate for the insurers to start kind of enforcing that expectation. And when I talked about the two-way exchange of information, a lot of times the insurers who are complaining have allowed the process of transubstantiation to go on, and they really are not engaging the doctor in the two-way dialogue, which is perceived by the doctor as patient-friendly. If the employer or the insurer is basically trying to manipulate the doctor to make a decision that's unfavorable to the patient on behalf of the employer or the insurer, that's a fool's errand. Mm-hmm. Mm-hmm. You're never going to get a doctor to do something they perceive as hostile to their patient.
Yeah. And there was another comment from an audience member, too. As a data geek, I've noticed that claim management systems often do not properly capture all the clinical information that would allow for systematic flagging of high-risk individuals. Similarly, I know communication via patient-provider via EHR is poor, and thus treatment and return-to-work outcomes may vary and suffer as well. So the question was, how do we improve overall communication between provider, employer, and patient? But it might be an open-ended question for everyone.
Well, actually, this is a very timely question, because at the cutting edge, I think now, the idea of doing some sort of formalized assessment of risk early on in an episode to identify that vulnerable subset, that is where the cutting edge is right now. And there has been a proliferation of clinical sort of screening questionnaires that can be used, and the really serious big data geeks, the neural network, big data people have also developed predictive analytics to try and identify them. So I'm going to be actually giving a presentation at the Disability Management Employer Coalition conference in August in Austin with a guy that is one of these big data predictive analytics people. And essentially, I think where we're going to be moving to is a shared language about risk, and an agreement that a patient who is at increased risk because they're more vulnerable, not because they look like they're a criminal, but because they're more vulnerable, that we ought to agree that the care management, the treatment pathway, and the claim management and the case management pathway for at-risk people should look different than it does for regular risk people, because those vulnerable people have more needs, and to really think through what the needs are in their situations and what's posing the risk, and to address those risks. I think that's where the cutting edge is going to be. But without a tool by which we create objective-looking data to decide who's at risk and who's not, this will not work. There needs to be a shared language of risk between the treatment end and the payment end and the workplace end in order to make this work.
Mm-hmm. And one last question before you move on to the next section. You mentioned beyond ODG. Is it malingering?
Oh, no, it can be a lot of stuff. It could be an employer. It can be an employer. I actually just saw a very interesting report. If you haven't ever seen it, the RAND Corporation, R-A-N-D, in California, did a report in 2010 that I just happened to have unearthed again yesterday called Do Return to Work Programs Work, or something like that. And it absolutely so clearly showed that often what will happen is the employer says, no, you can't come back until you're full duty. So we have to be really clear when the obstacle is on the doctor end because the doctor is not releasing them, or the employer end because the employer is not providing work, right? Those are the two places where the gateways are, and you have to be clear which one you're talking about.
Mm-hmm. Okay, great. I think that's all the questions for now. Do you want to take a few minutes to go through the remainder of your slides?
Well, I can't see how many people are still on. I have a few tips for dealing with some other difficult issues if anybody's still on, but if we're basically down to nobody, I don't want to talk to myself.
We have about 45 people still on.
Okay, well, so I'll just go on here for it's about 5 more slides, and there's some resources at the end. There are just some other thoughts and about difficult issues that have kind of come up here. One of them is this question about, like, what does professionalism look like in difficult situations? And I think the short answer is it looks like tough love. Patients, the ones who are kind of having difficulty, complaining, not getting better, and you start to sense that maybe they think that the best choice might be, or they can't see any other choice other than staying out of work, is I think, they can't see the future. They can't see the risks and the opportunities that you can. You're actually the expert, and you have watched people who have sort of complained and whined and whinged their way into life as an invalid with a miserable future and no job. And you've seen people with the exact same diagnosis who have figured out a way to cope, gone back to work, and whatever. And I think that since you have watched the differences in your patient population, I think you can speak it. You may have to find a tactful way to speak it. But the other part is that you don't have to say yes to everybody about everything. That managing requests and hurting and disappointing people is simply part of the territory of healthcare. If you think about it, we order bitter medicine, painful tests, and we cut holes in people's bodies. We give people bad news. We tell them they're going to die. We force people to get up right after they've had surgery and walk around with searing pain because we're trying to save their lives. We refuse to order inappropriate drugs, tests, and treatments. All those things are in alignment with preserving function and preventing iatrogenic invalidism. Don't teach somebody they're an invalid. Keep people functional. Keep them participating in life. Pat them on the butt and send them back into the game. And accepting loss, which I think also gets in people's ways, is an essential step in rehabilitation. I don't think we really understand quite enough yet about what are the things that create delayed or failed recovery. And I think part of it is sometimes this issue about accepting loss. That yes, stuff happens in life. Over the period of life, we gradually have more and more things happen to us. We get older, we get gimpier, and finally we die at the end. Like, that is the reality of life. And so we can maybe help people understand that that's what the homework is. Now, sometimes it's pretty clear that you feel like somebody's trying to manipulate you, and it's uncomfortable. These ideas actually came from a very wise rehab doctor in Arizona who has really thought through how to deal with an advocacy challenge, we're calling it. And she pointed out that being uncomfortable or upset and feeling manipulated is actually your problem, not the patient's problem. And that one way to look at it is they're simply trying to get what they want out of life, and that, in fact, all of us try and get what we want out of life. Some of us use different techniques to do it, but there's nothing wrong with people trying to get what they want or need. And so if we're uncomfortable or upset, we need to figure out how we're going to manage ourselves. So we get to choose what role to play as soon as we notice what's going on, and be very clear with ourselves about why are we uncomfortable, and then what do you need to do in order to get comfortable, because you're not going to be powerful in the situation until you get yourself comfortable. So she said, start thinking about what the outcomes are. You're in this kind of a situation, like, what's the outcome you want to have? And you want to have self-respect, and you want to have the patient feel respected too. And you want to feel confident that you've given expert and correct advice, and the patient needs to feel heard and cared about, and they need to respect your integrity, the independence of your decision-making, and your professionalism. Because, of course, once you've sold out, they now know you're a person who sells out, and they're going to come to you again to do the same thing. You want to feel masterful and grounded and centered and competent. You want to feel like your power has been used for the right thing, and you want to feel like your actions match your commitments. And if you stand up and have integrity, most often the patient will be willing to go along, even though they won't necessarily be happy, and they may or may not choose to stay in your practice. But you do not need to be diminished in order to, you can find your way through to a place where you have your own self-respect and you have not had to nuke the patient in order to do it. And specifically, in terms of some things that patients don't know, that it might be, it's in the unspoken, they haven't even thought of asking these questions. They often don't know that it's medically safe to work despite chronic pain. And that, in fact, most people with chronic pain do live pretty darn normal lives. They don't let the pain stop them. And they don't know that the limitations you've set are estimates. And they're facing a situation, and they're trying to figure out how to handle it. And they probably have never faced this situation before, and you've seen it a lot. You're way more expert than they are at it. And I think it's two things. One is to have compassion for them, that they are uncertain, and to provide them with guidance, and not to be irritated that they're asking, because it's not obvious to them, even though it may be obvious to you. Other thing they don't know necessarily is how the system works, what their rights and responsibilities are. And when people are feeling like they're in the dark and other people have information, they start to get distrustful. And so I think providing people, not necessarily that you take the time to do all the education, but that you either give them handouts or you point them to websites and say to them, it's important that you understand this. I want you to be fully prepared and equipped to handle with what's going on. That is the kind of thing where you're arming and developing the patient's ability to deal with what they're going on. The other thing that people don't know what else is possible is alternative jobs and careers. As I've started to work with people, who have really had bad outcomes, I'm discovering a lot of these people, they graduated from high school and their Uncle Vinny got them a job down at the plant. They don't have any idea what other things they might do. They don't have any idea how to look for a job. And so I think we're kind of blaming people for thinking there's only one solution when we don't really realize they simply can't imagine something else. And as I said earlier, they don't know what they're heading for if they think disability looks like the best answer. And again, the disability rights advocates want me to tell you, a life on disability benefits is a life of powerlessness and poverty. So, first precept of medicine, do no harm. Don't help patients become a casualty of the system. The work comp and disability benefit systems look like an easy solution to people who are faced with difficult life choices and predicaments. It looks like, some people call it the disability lottery. And these systems provide financial rewards to people who arouse sympathy, which creates an incentive to be as pathetic as possible. This is profoundly disempowering. By the way, where I've learned these is from disability rights advocates. So, under the do no harm flag, when social justice is an issue, be of assistance, but we have to be careful to avoid using the patient and ruining their future because we are righteously indignant about bad insurers or employers. It may be that the person is in a terrible situation, but their best long-term interest may not be for you to go to bat for them against that employer and insurer and end up on long-term disability. We want to encourage patients to see themselves as able to cope no matter what's happened. They can choose to be a hero rather than a victim. And there's a wonderful guy here in Massachusetts who got electrocuted while working on a ladder, and he was one of the first people ever to get a face transplant. And he, at one point in a newspaper interview, said, I had a choice, to get bitter or to get better. So really, when you start saying do no harm, what is more harmful? Is it more harmful to expect a person to return to work despite chronic pain, or to create a person who thinks they can never work again? Is it more harmful to estimate high and set only mild functional limitations rather than conservative ones? Or is it more harmful to have somebody lose their job and maybe their career because the employer can't or won't provide work within limitations you set, just basically by guessing? Is it more harmful to release a patient to regular work despite continuing symptoms? Is it more harmful to tell somebody it may be time to think about finding a new job, or have somebody stay on disability for months or years and lose their ability to even get another job? So there are trade-offs we have to make. So, and the rest here is there's readings for you on the worklessness and this is biopsychosocioeconomic model. Readings on multidimensional care, which is if we are going to work in a biopsychosocioeconomic model of sickness and disability, we are going to have to care for people in a multidimensional way as well. For patients with chronic pain, there's some wonderful resources here. I have been trying to put together resources that don't require there to be practitioners in your community who do not exist, and that don't require the payer be willing to pay for stuff that the person needs. So these are all very low cost or free ways to help people. Mental health resources for patients, again, these are all free, or just, the cost of a book. And if you have any more comments or questions, please send them in to Angie, and we'll be happy to answer them later. And I'm so grateful you stayed on and that we had this time together. I wish we were all face-to-face.
Great, Jennifer. Thank you so much for the presentation. Very informative, and definitely to our audience members, if you have any additional questions, don't hesitate to email me and we can pass them on.